Hello, this is student music therapist Suzanne Osman, and I am presenting on music therapy with autism spectrum disorder. My current practicum setting is with a day school at Giant Steps Autism Organization in Lisle, Illinois. The organization provides a variety of training and services that are meant to educate the public as well as families about autism. They also provide therapeutic services, recreation, and life skills for their students. And the students at the school range in age between 5 and 22 years old. Autism has been labeled a spectrum disorder because the symptoms range from mild to severe, and they often overlap. Autism spectrum disorder is a pervasive developmental disorder. It's caused by abnormality in brain development, and there's a lower number of Purkinje cells in people with autism. It is also noted that susceptibility is inherited, and environmental factors play a role in whether or not a child develops autism. There currently is no cure. Autism was first described in a medical journal in 1943 by a physician, Leo Kanner. He writes, "The children did not interact emotionally with others, became extremely upset by any break in routine, fascinated by objects, and used language strangely or not at all. And this brings me to my client, B, a 12-year-old male whom I've been observing over the past 14 weeks. B displays a lot of the typical symptoms that are associated with severe autism. He is nonverbal. He lacks facial expressions. He has very poor eye contact, regularly makes unusual vocal noises, and displays stimming behaviors. He also has a extreme sensitivity to touch, light, and sound, so a variety of sensory inputs. He demonstrates a lack of coordination, impulsiveness, and toe walking. A more complete list of symptoms associated with autism can be found in the Diagnostic and Statistical Manual of Mental Disorders. B was only recently admitted to the Giant Steps Day School. This is only his second year at the school, and previously he was enrolled in a mainstream education program. He currently takes medication for a gastrointestinal disorder, and the medication causes episodes of insomnia. In working at Giant Steps, the nature of autism and its relation to brain development, the music therapists on staff are neurological music therapists, and they are all certified in NMT. My initial observations in the sessions were that B displayed difficulty with understanding directions, expressing himself or what he needs, the sensory integration, processing information. It was very hard for him to focus or filter out any auditory or visual distractions. And he also had a hard time transitioning into the music therapy session. I observed a variety of musical and non-musical response. B would have outbursts of short screams, or he would hit the corners of his head with his hands if he grew frustrated or agitated. And he showed minimal interaction with the one other client in our session. He had moments of spacing out. However, he was able to look towards the source of a sound. And he responded very well to alternative communication systems, including pictures that would be attached by Velcro to his binder and his iPad. Dr. Dorita Berger claims that you must prepare the body and brain for learning. Responses are based on how the brain receives and interprets incoming sensory information. Therefore, any misinterpretation of information can result in fear, stress, and a fight or flight behavior. So this suggests the importance of the physiological aspects of autism and music therapy. The interdisciplinary teams at Giant Steps do a wonderful job of working together to create each student's individual education plan. There are 8 neurological music therapists on staff at the school, and they must collaborate with other members of the team in order to create goals and objectives. These members could be teachers, occupational therapists, physical therapists, speech pathologists, or applied behavior analysts. And getting back to Dr. Berger's focus on the physiological aspects, I've created 2 main goals for B. Goal number 1 is to reduce physiological stress and anxiety. And this is simply in order for him to relax so that the music therapy interventions can be more effective. So in connection with that goal, the objective 1 is in an environment with limited visual and auditory distractions, B will undergo 5 minutes of a calming activity with therapist prompt. In goal number 2, hones in a little bit more on his immediate needs. That is to regulate breath control and oral motor skills for language development. Objective 2 is that B will achieve blowing of sustained tones on the slide whistle when verbally prompted by the music therapist in 3 out of 4 trials. in considering the therapeutic approach, B has grown accustomed to the structure of the NMT sessions. And this routine and this structure has helped B with time. We normally begin with a hello song, and then we try and identify what B is working for that day. So we might just ask him, "What are you working for today, B?" And he'll turn to his iPad, and he'll press the "I want" button, and then he'll point or press the icon for snack or playtime on the swing. Then we'll go back and use music listening or singing activity for a calming effect, using a familiar song. And once we are able to bring B into the musical element, we'll take a little break. He has a very short attention span. We try not to overwork him so as to avoid frustration or agitation. And once B is feeling a little better, ready for more, we will continue work on breath regulation and oral motor skills. Generally, we like to use a slide whistle or a kazoo because we found that the harmonica requires quite a bit of oral motor skills to produce sound. It's much easier to make sound out of a slide whistle. We'll follow that with a break, and then we'll close it out with an activity and a goodbye song. The NMT therapeutic methods, main method that we like to work by is a transformational design model, which allows for functional interventions to address the client needs. Clinical improvisation enables us to use improvised lyrics with familiar songs to motivate or to prompt B towards a specific behavior. Developmental speech and language training also focus on targeting speech and language skills. B has made significant progress over the past 4 months. Greater ease with transition into music therapy, regular participation with the interventions, much less self-stimulating behavior. He shows signs of increased awareness and an increased duration of sustained notes that he can play now on the slide whistle, which kind of suggests an improvement with oral motor skills. He has an improved attention span, and he is now able to more clearly pronounce the words hi, bye, done, more, and Cheez-Its, which happens to be one of his favorite snacks. Sometimes B's tolerance and his mood can be a little inconsistent following a long holiday break or an episode that he may have had in connection with insomnia and his condition with gastrointestinal disorder. We try and vary the level of participation and minimize distractions in the room. Let him take a nap if that's what he needs, and just kind of make the staff and some of his peers aware of the situation of his mood that day so that they can support us. Ongoing music therapy is highly recommended for B. 45-minute sessions 2 or 3 times a week, continued use of the model, and a gradual increase language development goals. Thank you very much. That is my presentation.